Um, Pre-rheumatoid typically refers to the early phase or preclinical stage of rheumatoid arthritis, RA, before the full-blown disease manifests. During this stage, patients may not meet the formal criteria for RA diagnosis, but they can show signs that suggest they are at risk of developing the disease. Key characteristics of the pre-rheumatoid stage include 1. Genetic predisposition. Individuals with certain genetic markers, e.g., HLA-DRB1, may have a higher risk of developing RA. 2. Autoantibodies. Presence of autoantibodies like rheumatoid factor, RF, and anti-citrullinated protein antibodies, ACPA, can be detected in the blood even before clinical symptoms appear. 3. Subclinical inflammation. Imaging studies such as ultrasound or MRI may show early joint inflammation or synovitis before it is evident in clinical examinations. For nonspecific symptoms, patients may experience vague symptoms like joint stiffness, fatigue, or mild joint pain without the typical swelling or deformities seen in established RA. 5. Environmental factors. Smoking, infections, and other environmental triggers can also be linked to the onset of RA. Identifying individuals in this pre-rheumatoid stage is important for early intervention and potentially delaying or preventing the onset of RA. The need for treatment during the pre-rheumatoid stage is still a topic of research and debate. However, the goal of early intervention is to prevent or delay the progression to full-blown rheumatoid arthritis, RA. Here are some considerations regarding treatment in the pre-rheumatoid stage. 1. Risk assessment. Not everyone in the pre-rheumatoid stage will develop RA. Therefore, a thorough risk assessment, including the presence of autoantibodies like ACPA and RF, genetic factors, and imaging findings, is crucial in determining the likelihood of progression to RA. 2. Monitoring. For individuals at high risk, close monitoring with regular follow-up appointments, imaging, and blood tests may be recommended. This allows for early detection of any progression and timely initiation of treatment. 3. Lifestyle modifications. Smoking cessation, weight management, and reducing stress can be important in managing risk factors for RA. 4. Preventive treatment. In certain high-risk cases, some clinicians may consider early intervention with disease-modifying antirheumatic drugs, DMARDs, or biologics to prevent the development of RA. Clinical trials are ongoing to determine the effectiveness and safety of these treatments in the pre-rheumatoid phase. 5. Symptomatic treatment. For patients experiencing mild symptoms, treatments such as nonsteroidal anti-inflammatory drugs, NSAIDs, or physical therapy may be used to manage discomfort. Ultimately, the decision to treat during the pre-rheumatoid phase should be personalized, taking into account the patient's risk factors, symptoms, and preferences. Early consultation with a rheumatologist is essential to tailor the best approach for each individual. Ultrasound plays a significant role in detecting subclinical synovitis in patients at risk of developing rheumatoid arthritis, RA. The presence of sonographic synovitis, even in the absence of clinical symptoms, can provide important insights into the early stages of disease progression. Here's how ultrasound findings can influence treatment decisions in the preclinical phase. Heh. Role of ultrasound in preclinical RA. 1. Detection of subclinical inflammation. Ultrasound, particularly power Doppler, can detect synovial inflammation, synovitis, that may not be evident on physical examination. This is crucial because subclinical synovitis has been associated with progression to clinically apparent RA. 2. Risk stratification. Identifying sonographic synovitis in patients with positive autoantibodies, e.g., ACPA, RF, or genetic predisposition can indicate a higher risk of progression to RA, potentially justifying closer monitoring or early intervention. 3. Monitoring disease progression. Ultrasound can be used to monitor subtle changes over time, helping to identify patients who are progressing towards clinical RA. Justification for DMARD use, based on sonographic synovitis. 1. Evidence from studies. Emerging evidence suggests that patients with sonographic synovitis, even in the absence of clinical symptoms, are at higher risk of developing RA. Some studies have shown that early intervention with DMARDs or biologics in patients with subclinical synovitis may delay or prevent the progression to clinically overt RA. This approach is sometimes referred to as preventive treatment or window of opportunity treatment. 2. Guidelines and clinical practice. While current guidelines, such as those from the EULAR, European League Against Rheumatism, and ACR, American College of Rheumatology, have not universally recommended DMARD solely based on sonographic findings in asymptomatic patients, they do recognize the value of ultrasound in risk stratification and decision making. Some experts argue that in patients with high risk features, e.g., positive autoantibodies, genetic risk factors, and sonographic synovitis, early DMARD use could be justified, especially if the goal is to prevent progression to RA. Number 3. Individualized approach. The decision to start DMARDs based on ultrasound findings alone should be personalized. Factors such as the patient's risk profile, the extent and persistence of sonographic synovitis, patient preferences, and potential risks of DMARD therapy should all be considered. In some cases, initiating DMARDs early could prevent irreversible joint damage, while in others, a watch and wait approach with close monitoring might be more appropriate. Clinical scenario consideration. High risk patient. For a patient with sonographic evidence of synovitis, positive ACPA RF, and a strong family history of RA, the presence of sonographic synovitis may tip the balance towards early DMARD therapy even in the absence of clinical symptoms. Low risk patient. In contrast, a patient with isolated sonographic synovitis but no other risk factors might be managed with close monitoring rather than immediate DMARDs. Conclusion. The presence of sonographic synovitis can indeed be a strong indicator of future RA development, and in selected high-risk patients, it may justify early DMARD use. However, this approach should be personalized and the risks and benefits carefully weighed. More research is needed to refine the criteria for initiating treatment in this preclinical phase based on ultrasound findings. In cases where pre-rheumatoid patients with sonographic subclinical synovitis have been treated with DMARDs and follow-up ultrasound reveals no active synovitis, the decision to stop DMARDs is complex and must be approached cautiously. Here's how this situation could be managed. SHAP stopping DMARDs after synovitis resolution. 1. Assessing remission versus low disease activity. The complete resolution of sonographic synovitis suggests that the inflammation has been effectively controlled. However, it's essential to determine whether this represents true remission, i.e., the absence of ongoing immune activity, or just a temporary suppression of symptoms. Laboratory markers, e.g., CRP, ESR, autoantibody status, and clinical assessment should also be taken into consideration before deciding to stop treatment. 2. 2. Gradual tapering versus abrupt stopping. Instead of stopping DMARDs abruptly, a gradual tapering approach may be safer. This allows for the monitoring of any signs of disease reactivation while minimizing the risk of an immediate flare. The tapering schedule would depend on the specific DMARD used, and the patient should be closely monitored during this period. Follow-up precautions after stopping DMARDs. 1. Regular monitoring. Frequent ultrasound examinations. Regular follow-up ultrasounds, possibly every 3 to 6 months initially, can help detect any early signs of subclinical synovitis recurrence. Laboratory tests. Monitoring inflammatory markers, e.g., CRP, ESR, and autoantibody levels, ACPA, RF, can provide additional information on disease activity. Clinical assessments. Even in the absence of ultrasound findings, periodic clinical evaluations are essential to detect any subtle symptoms suggestive of relapse. 2. Patient education. Patients should be educated about the importance of promptly reporting any symptoms, even minor ones, such as joint stiffness, pain, or swelling, which could indicate a relapse. Lifestyle factors such as smoking cessation, maintaining a healthy weight, and managing stress should also be emphasized as these can influence the risk of relapse. 3. Imaging and biomarkers as early warning tools. Advanced imaging. Beyond standard ultrasound, some centers may use MRI or more sensitive ultrasound techniques to detect even earlier signs of inflammation. Biomarker research. Research is ongoing into new biomarkers that might predict relapse after DMARD discontinuation. If available, these can be incorporated into the follow-up strategy. Risk of relapse. High risk factors for relapse. Patients with high titers of ACPA or RF, a strong family history of RA, or certain genetic markers, e.g., HLA-DRB1, may have a higher risk of relapse after stopping DMARDs. For these patients, a more conservative approach with continued low-dose DMARDs may be considered. Low risk factors. For patients with lower risk profiles and complete resolution of synovitis, stopping DMARDs may be feasible, but with vigilant follow-up. Conclusion. While it may be possible to stop DMARDs after the resolution of sonographic synovitis in pre-rheumatoid patients, this decision should be personalized and involve a careful tapering approach. Close follow-up with regular ultrasounds, clinical assessments, and laboratory monitoring is crucial to detect any early signs of relapse. Patient education and lifestyle modification also play important roles in preventing future relapses.